My talk, as Maria said, is more focusing on the policy responses for human resource in health, particularly taking COVID-19 as a case example. This is a study we conducted under the consortium, the Reveal for Resilient Consortium. Myself and a couple of colleagues from HED International, also Maria, Sophie from Queen Margaret, Tim and Joe from Liverpool School of Tropical Medicine. Allow me to present next few minutes. Primarily, my presentation will cover the context of Nepal, looking at the federalized power structure and functions, and understanding how the HRH, the policy space, evolved within this context, and coupled with various other crises in the meantime. Also, the multiple shocks and stressors that primarily lead, I call it polycrisis situation, to human resource and health. And finally, I'll end with the policy responses and impact with the examples from COVID-19. As some of you probably know, Nepal had a massive political transformation from the unitary to federal system. Many people do confuse with the decentralization, massive decentralization, but it's a more political devolution rather than merely a decentralization, with the 3 tiers of government, federal and 7 provinces and 753 local government. While federalism is progressing over the years with the defined functions, but the clarity in terms of the various roles and responsibilities and allocation of resources and management of resources, particularly in health and other basic services, had to be fully realized and institutionalized. When it comes to the health system, yes, obviously it is coping with the multiple strategies to really align the health system's transformation within the new structure, while there are opportunities as well as challenges to this restructuring process. In particular, the adjustment of the human resources across the 3 tiers of government, moving from unitary control to the federalized system. The HRH itself, it's a complex issue. Perhaps the region is resulting a weak policy space and actions. However, the federal, provincial, and local government, the formulation of policy standards is largely the federal. Provinces, basically the provincial level policy and coordination, and large chunk of health service delivery, primarily the basic healthcare service delivery, with the development of brand and programs, falls at the local level. My title is basically, do we have enough understanding in the policy space? Not just HRH as a critical pillar of health system, do we understand? Often what we hear is health workers is doctors, nurses, laboratory technicians, plus. But if you look at the definition of WHO, anyone who works for health benefit are of the general public considered as a health worker, and human resource for health is more than 200 types of human resource for health. I think what is underpinning is the comprehensive understanding of what the HRS involves and how it operationalizes within the given context in country. Its policy space are limited, especially when it comes to the crisis, context of the crisis. The HRS is not viewed holistically, so the policy has limitations. With regard to Nepal, I mean, it's a crisis is not one time. We are living with the multiple crises over time, starting from 1996, 2006, the civil war. If you look at the common issues across the various crisis period, it's very similar to HRS. I mean, the fear of kidnapping during the crisis conflict that reflects from the Oliver presentation as well, as the violence, injuries, and poor infrastructure, so on and so forth. But also the people's movement that had some common issues, and the earthquake, massive earthquake, 2015 hit Nepal with the largely damaging the health facilities in highly affected districts their pretty much risk to the losses of family members and health workers. COVID-19, which is my particular focus in this talk, has a lot of common issues, and also ongoing these outbreaks and the recent earthquake in Jazarkot in 2013. So the message I'm trying to present here is human resource in health do live in ongoing crisis, shocks and stressors that limits their ability to deliver the services if the policy response are not mature enough towards creating enabling environment for them. Well, with this multiple crisis, can the HRS be more resilient to respond this? Looking at the current numbers. For example, if you look at the recommended level of the minimum requirement of human resources, which is 4.5 per 1,000 population, but Nepal currently stands with 1.4, with a very limited doctors, nurses, and auxiliary nurse midwives as an example. And majority of these healthcare providers, particularly the doctors, are male-dominated. So with this distribution and to really balance this distribution in order to support the crisis through the resilient health workforce, we do need to think policy from the longer perspective and creating enabling environment with these sizable numbers. And it leaves the question whether the human resource, human of the human resources is maxed with the multiple shocks and stressors, because we have this prolonged epidemiological transition where we were, in particularly LMIC context, where the communicable diseases was high, now increasing number of NCDs, but no less the communicable diseases as well. And the climate-sensitive diseases and lack of mechanisms, institutional mechanisms and policy mechanisms for motivation and incentive, and then systematic transfer, so on and so forth, including the balance between the global demand and supply and benefits of the HRH has really marks the human aspect of the broader human resource for health. Right, with this context, our research questions were really looking at the HRS policy response within the COVID-19 across the 3 tiers of government, and how the processes, particularly the formulation of policy, communication, and its implementation, monitored and executed all across the 3 levels. And the health workforce management, particularly local adaptation, local innovation in response to COVID-19. We had this cross-sectional study using the mixed method document review and the key informant interviews across the 3 tiers of government. Also the researchers' reflection as member of the policy formulation group, and we analyzed using the thematic analysis. We adapted the Rebuild for Resilient research framework to the local context, particularly looking at the inclusion and decision-making, monitoring and intersectoral collaboration, communication of the strategies, and the decision-making space across the 3 tiers. With this, looking at, yes, there was not dearth of the policy development linked to the human resource for health. Most of the policy evolved during the COVID-19 period. We take from January 2020 to the December 2020. A lot of policies were developed, and they have mentioned about the human resource mobilization in particular across the various levels. But looking at the number of policies developed, how effectively they were communicated to the local level. These were the various policies, and the major focus highlights. It talks about recruitment, workplace safety, capacity building, safety, protecting the physical and mental health of the human resource for health, monitoring and evaluation, supervision, regulatory adaptation, so many things. However, what we found is that there's a considerable gap in the federal policies when it comes to the gender equity and social inclusion and justice. However, there was some adaptation to the sensitive aspect of the gender dimensions within the local government, where they did consider, like, for example, pregnancy status of healthcare providers their age and their comorbidities in terms of dealing with the issues related to COVID-19. So these were the major policy. The policy formulation, if you look at the structure process and inclusion process, largely policies were formulated at the federal level with a very minimal decision space to the local government, subnational government. And this policy formulation process was largely reliant on the issues that were observed at the federal level. Because of the context, it was very minimal participation from the subnational government. Also, the intersectoral coordination was evident, but limited to the virtual consultations, which restricted the contextualization of the policies at the local level, bringing the real ground issues to the policy, so the operationalization policy could be spent. Again, gender equity and justice were not well reflected, as I said earlier. Looking at the communications policy, it's in three aspects. One is the multiple channels were used, and there was a very top-down approach of communicating policies that ended of the lack of clarity in terms of policy implementation at the local level, and that led to the suffering of the healthcare providers. The various channels were used inconsistently, and an absence of a targeted communication during the crisis, and tailored communication according to the audience was an issue. The top-down approach, basically, the subnational government was less aware about the evolving policy decisions, and the changes were made at the federal level that resulted suffering of the routine services as well as the services for the COVID-19. And particularly the local government had a mechanism to communicate with the frontline healthcare provider working at the subnational level by whatever means available, largely using the mobile phones, and some of the written forms. Mostly the information that healthcare providers gained at that time mostly relied on the social media, not necessarily as the very authenticated official sites. So there was a limited access to internet and other platforms as well to the healthcare providers. We looked at the motivation and support to the healthcare providers. Looking at the policy provision, yes, it did talk about the risk allowance, health insurance, and appreciation and reward. However, the unfolding the policy to the operational level, there were a number of issues we observed that led to the untimely allowances and the differences between the local government that led to the low motivation of the healthcare providers. Also, the leave and holidays, the support system, support mechanisms was there, but due to the shortages of the staff, the no leave and holidays were approved, and there was no weekend for majority of the healthcare provider crisis time. On the physical safety and protection, yes, the PPE, the personal protective equipment, and other safety items were required to be delivered on the ground to the frontline healthcare provider. However, it was consistent shortage, and they had to operate in a very limited and protective environment within their health facility and the community. That all led to the low motivation of the healthcare provider. Increasingly, it was a mental safety, stigma, and discrimination, and this is particularly the experience from the healthcare provider, as a mounting number of fear among the health workers because of the insufficient information. And the healthcare providers did face the social, stigma and discrimination in their community, particularly during the very initial phase of the COVID-19 response, that resulted a restriction to use the community facilities, including the tap water, toilet, and the swapping facilities. And the community blocked the healthcare provider to enter to their community because of the fear that they would be carrying COVID-19 agent and the neighborhood threatening. The latter, as subsequently COVID-19 response progressed, the federal government realized that they had to issue a policy directives to really respond to this. And this is my final slide, looking at the key lessons on the policy response during the crisis to make the health system more resilient. There are four important areas: the participatory and inclusiveness during the development of the policy, linking, really hearing the voices of the frontline healthcare providers to inform the policy so the policy can be implemented effectively. That required really including the vertical and the horizontal level of stakeholders, in-person, more in-person rather than virtual consultations. If the enforcement is not feasible, virtual consultation during the crisis is important, and improving the feasibility and the ownership while developing the policy with the greater consideration of gender equity and justice in the HRS policies. The second is the effective communication. The established mechanism across the different tiers of government to ensure the consistency in the understanding of the policy. So the federal, it's a top-down approach. Of course, we've seen quite a lot in several countries, like in Nepal, doesn't work. I think we need to establish a platform, a mechanism where the communication is more efficient and targeted communication. On the mobilization of health workforce, the plan, it's absolutely critical. The adaptive leadership and management across the levels for the redeployment and task reallocation and safety and a functioning HRS system. We did suffer quite a lot in terms of obtaining information, who is working where, in absence of a crisis HRS information management system with the robust evaluation and learning on it. The strategic approaches to engage, in continuous capacity development, motivation of the health workforce is very critical, particularly during the crisis, and balance incentive package, recognizing the efforts of the healthcare provider, that's really acknowledging the human resource for health is pretty critical here, along with the supportive infrastructure. So the policy space, we need to really contextualize it. It needs to be reflective as we continue to implement the policy. Adaptation has to be smooth with a good communication and support mechanism. These are the few glimpses how human resource, particularly in the diverse and complex geographic setting in Nepal, deliver the COVID-19 response to their best level of effort. Salute to these heroes who work really in the crisis. Over to you, Maria. Thank you.
Thank you.